Next up on primary care, high blood pressure. Sadly, it's about as common in the African American community as going to church on Sunday morning.
But we also have about 99 medications right now that we can use to stem the epidemic of hypertension in African Americans.
Hello, and welcome to Primary Care. I'm your host, Dr. Lonnie Joe. In 2017, the American Heart Association and the American College of Cardiology changed the guidelines for diagnosing high blood pressure. Now, anyone with a pressure of over 130/80 is considered to have hypertension. The medical definition of blood pressure is when the force of blood flowing through your blood vessels is too high. The high blood pressure adds to your heart's workload and can cause heart disease and heart failure. Here to give us more information is Dr. Kenneth Jamerson. Dr. Jamerson is Professor of Internal Medicine and is the Frederick Hurrell Collegiate Professor of Cardiovascular Medicine at the University of Michigan Medical School. He is also an advisor to national and international clinical trials that examine the impact of hypertension control on global populations. Dr. Jamerson, welcome to the show. Ken, always a pleasure to see you.
It's a pleasure to spend time with you.
Great. Ken, the new guidelines for the control of hypertension have come out, and basically, how is this affecting the population that we see? Are they accepting of it? Are clinicians accepting of it? And what is the outcome on patient and control rates?
When you mention guidelines, it's a process where most developed countries every 4 to 5 years, look at all the evidence. Are we doing better? What are new drugs? And should we change things? Well, in the United States, it hadn't happened since 2003. And in 2017, November, groups sanctioned by the NIH, American Heart Association, American College of Cardiology, did such an exercise. We made 109 recommendations. So it affects a lot of people in a lot of different ways. And importantly, if you've been told in the past that you have borderline hypertension, the next time you see your provider, he may tell you you have stage 1 hypertension. So we redefine what the levels are for conferring the diagnosis of hypertension, what the targets are, and we identify that if you adhere to these strategies, you likely are going to live longer without a heart attack or stroke.
So basically, the numbers have been readjusted, which means different approach, maybe a different diagnosis, and different action required on the part of the primary care physician.
And I didn't forget that you said, how are people accepting it, and is there any controversy? I just specifically decided not to answer it, because what we did is look at data, and the data says that lower is a bit better, and even if you don't feel that way about it, or if it's your opinion that may not be the case, the data are the data, and a lower blood pressure confers a better cardiovascular risk.
So how is this changing our approaches to treatment? Because to treat high blood pressure means we've got to address certain things. So what are we doing differently now that we have new guidelines?
I think we need to focus on making sure if we're going to treat based on a number, that number is absolutely accurate. So consider walking into a doctor's office. You get there, it's taking you a while, traffic's bad, you have to find the building. Somebody throws a cuff over your shirt, hits a button, and says that's your blood pressure. And as a healthcare provider, you're supposed to use that number to manage them every day of their life based on that. So with these new guidelines, we really stress out-of-office measures to actually be able to get a cuff, to bring it into your healthcare provider, have it calibrated, and do some blood pressures at home when you're relaxed, and we can get truer blood pressure readings. Also, on the healthcare provider side, we're asking them to buy validated cuffs to do the technique correctly. Have people wait 5 minutes before you take the blood pressure. So importantly, we want to make sure if we're going to give you a diagnosis, that number is really accurate. So that's one of the first things we start with, getting an accurate number, using home monitoring to make sure you're controlled at home. And we're implementing more medication only at certain thresholds. So here's a new thing you have to do as a provider. You can't give them the number anymore. Your blood pressure is this. Importantly, there's some people who might be comfortable at 140/90, and others you need to, no option, you need to go to 130/80. And they won't know unless you tell them. So now patients need to have a conversation with their provider. Which one am I? Do I have to be at 130/80? And as a provider, you have to do a new step. So we're giving you new work. You better pull out your calculator, your iPad, or on your computer, run through the HA risk factor equation. It plugs the numbers in, and it gives you a risk. And if that risk is 10%, that is an individual that needs the 130/80 target. I don't care how you feel about it. I don't care about the controversy. The data suggests that that 130/80 target is going to let people who have a 10-year risk of having a cardiovascular event live longer without that heart attack or stroke.
So we're not throwing the numbers out the window. We're basically repositioning the numbers along with other data that's collected to make the recommendation, and the pressure may not be given to the patient as a number, but you're certainly put in a category, and that category is maybe you're at higher risk than other people in the population for all these bad things that happen behind uncontrolled high blood pressure.
Yes, so the group that has nothing to worry about is the group that's 120/80 or less. But when you exceed that threshold, we like you to do other things. Be cautious about salt. And if you get anything down the aisle of a supermarket, you're getting salt. Salt lives on shelves. If you're in the periphery where there's fresh meat and produce, you may be able to limit your salt. We also ask people to some extent, get their muscles pumping. When I give you a drug to lower your blood pressure, it opens up blood flow. I can open up blood flow to your fat or to your muscle. Sending you more blood to your fat does nothing for you. But when you do that exercise, you direct that blood pressure medication to work more on the muscle that's exercising. It needs nutrients. So you intensify the effect. And even after you stop exercising, you get a prolonged effect. So whether you're taking the pill or not, that activity can lower your blood pressure. And then lastly, mind-body. We're more and more emphasizing that mind-body connection to naturally bring your sympathetic drive down lower with breathing exercises as well as mindfulness and meditation.
So the caution to a patient to calm down works.
Absolutely.
We've had decades of treating hypertension in African Americans now. We've collected a lot of data. Where do we stand? Are we making progress? And if we are, is that progress adequate?
There are two ways to answer this question. You and I have collected data, and it's been really important. So a couple decades, we collected data to find out, is there a way to retard the progression to dialysis that blacks were disproportionately predisposed?
That's the ASK study.
The ASK study. And you helped us. We appreciate that. And we found out that there are particular drugs that can slow the progress. But you know what? We also kept a sample on the side, and we biobanked that. And 20 years later, we found out not only is there a better treatment, but there's a genetic predisposition. There's a gene that was prevalent in West Africa that prevented you from getting tsetse fly disease, that now in US blacks comes up as a risk factor for a specific form of kidney failure. So what's going on is that we have more options with research. We're evoking new strategies. When you get at genomic causes, you get specific targets that you can shoot for, much like we see in breast cancer and other cancers. And so we're emerging on looking at mechanisms of hypertension, and we're emerging on being able to find new therapies that are more based on the actual cause and not just treating with drugs.
Is there a place for genomic testing in high blood pressure now?
There is. And more, I'm working with those who know how to do that well, to pose questions, to involve more African Americans. When I look at the progress that's being made, it's usually in cohorts that are exclusively European, and in the US, it's mostly Caucasian cohorts. So although blacks are predisposed to cardiovascular disease, we're not frequently represented in those studies. Can I go askew just
Sure,
a minute?
go right ahead.
There's an exciting new therapy for cholesterol, and I'm sure you know this. It was gleaned from observing blacks. Blacks had fewer heart attacks. They looked into why. They found this PCSK9 gene, and activity around that PCSK9 gene is the hottest, newest expensive therapy for cholesterol medication.
Very expensive.
So we're important. We don't get the benefit. It's very expensive.
And we can't afford the drug.
We can't afford the drug. But that technology, the idea that you can get at root causes and that sometimes looking at genomic approaches is helpful, I think is where our future is.
Right. That was very exciting because if it exists in that arena, what else is out there that can give us the same kind of data to act on? Right?
A lot. And with big data science, you can run so many possibilities that this is our future, and it's foreseeable that we'll be able to get there. We know it now that there are 21 genes between your mom and your dad that you get that predispose you to develop high blood pressure.
Ken, hold that thought. We've got to go to a break. We'll be right back because I'm sure you've got lots of follow-up on that, including all the data. We'll be right back with more Dr. Ken Jamerson on the treatment of high blood pressure in African Americans.
150 over 90.
180 over 111.
160 over 110. I had a stroke.
This is what high blood pressure looks like. You might not feel its symptoms, but the results from a stroke are far from invisible or silent. If you've come off your treatment plan, get back on it or talk with your doctor to create an exercise, diet, and medication plan that works for you. Go to loweryourhbp.org.
If I would have followed a treatment plan, I would not be in this situation.
Welcome back. We're here with Dr. Ken Jamerson, professor of internal medicine at the University of Michigan Medical School and hypertension researcher par excellence. Ken, we're again so glad to have you on the show. We left off talking about what's the meaning of this genetic testing as it relates to the treatment of hypertension. Now, you and I go far back enough when that was just a thought. We knew something was out there, but we didn't know what it was. You saw activity in the research arena, but we couldn't put our finger on it to say, this has an effect for this particular population of patients as it relates to hypertension. So I guess we've arrived.
Okay, I don't want to be that enthusiastic that we arrived. We're realizing that we have the technology to build a future. We have supercomputers. We know the human genome. We can, in many ways, get at participating genes. So there are about 21 genes we know of now that between your mother and your father, you're going to get.
Right.
And they predispose you to high blood pressure. But that's not the whole story. And you know I like research, and you know I like to talk about things that could happen in the future. But we also have about 99 medications right now that we can use to stem the epidemic of hypertension in African Americans. So I want you to be excited. I want you to, when you think about it, refer patients to biorepositories so that we are included, because right now we're not. We're helping non-Black populations control their cholesterol. We're not getting the benefit because we're not in the studies very often. But at the same time, I understand there's some practical things we can do now to get a real grip on getting blood pressure better controlled.
How are the new guidelines going over with patients and providers?
I think with providers, there are a few schisms. The idea of writing a guideline is you bring organizations together, and there's an organization that represents family physicians, and there is an organization that represents internists, the American College of Physicians. And when this process was being unnerved, they decided not to participate. And so now that the results are out, they judge them and critique them. And you've asked me this now twice, and I told you it really doesn't matter what people's critiques are or what they think, that in some ways there is data that lowering your blood pressure will help you live longer without a heart attack or stroke. Do we want to have a controversial conversation about that, or do we want to accept that as fact?
We want to accept that as fact because the older we get, increases the chance of us developing hypertension anyway. Let's shift gears for a minute.
Yes, sir.
Hypertension and the effects on the heart. We know a lot of stuff about that, but we still seem to see disproportionate outcomes with African Americans and heart disease, and particularly congestive heart failure, as a root cause being hypertension. Where are we?
We're at a place where we know all the facts, but they're not coming together to give us the outcome that we really want. And I wish I had one thing to say that was wrong, but I think part of it is that you can look at a young, healthy African American and they have high blood pressure, and it doesn't occur to you how much risk it's really conferring on them. Hypertension is so dangerous to young Black people that many times, so I would say when we were learning medicine, people thought Blacks didn't have heart attacks.
Right.
They really thought we didn't have heart attacks. Why? The blood pressure was so high, you had a stroke before you could ever build up plaque in your arteries to have a heart attack. And this is an odd thing to say, we have progressed. Blacks are living long enough now to have coronary artery disease, and they're not dying exclusively of strokes. So there's more work to be done. The more you bring blood pressure down, the longer people live, and chronic conditions like atherosclerotic disease are now at the forefront. We know they affect men and women, and I really want to state that the idea that Blacks are less likely to have coronary artery disease is something of our past, and anything to be proud of, but it does represent some of this progress that you asked me to point to.
You just touched on it, differences between men and women in high blood pressure, the sequelae of it, and the treatment.
So we systematically reviewed and decided that there's absolutely no difference in the treatment for hypertensive men and in hypertensive women. We do understand, though, that when women have coronary disease, they present quite differently. But for hypertension, no gender differences.
So in our community, patients often, for various reasons, skip medication. We still have to deal with that. That's an educational situation, a constant mantra that has to be preached, so to speak, in terms of compliance. What things can happen to improve on that treatment? By the way, secondary question, where are we in terms of percentages of control in the African American population?
Okay, the percentage of control is like a statistic number, and I'll provide that. And I do have some research issues related to compliance, but I hope you join in the answer because you actually treat patients, and you were treating patients when I was learning how to treat patients, so this communication would be enhanced by your opinions. When it comes to control rates, 90% of Americans or African Americans know about hypertension, and it's getting to a point of other people who know about it, almost 70% now are getting their blood pressure controlled. That's huge progress. Why are there problems with compliance? One thing that you've noticed and I've noticed is that if you take a sample of medication and tell a patient you need this drug and you put it in their hand, they may or they may not take it. The very first clinical trial I had from NIH, we could bring people to a clinic visit, give them transportation. We told them we give them medication not only for our study, but every medication they take, we would provide. And we told them we'd pay them for coming to a clinic visit, and only 40% of people came. But our study coordinator called, and they had reasons. So what am I getting around to saying? In my research findings, I find out that people may not be amenable to me preaching to them in the office about what they need in their lives, because on that particular day, what they prioritize and what's important to them may not be taking the pill because I told them to. But if we were to ask them what's going on and give them a chance to respond, that rate of 40% went up to 95%. And people in our research practice engage with us if we stop to ask them what's important to them rather than always preaching to them about what they should do.
So we basically have missed some of the social associated situations that affect compliance. We have written prescriptions, we've recommended medications, and we expected patients to comply without taking into consideration some of the other things that were involved in their day-to-day activity.
Absolutely. And that's what research shows me and that we could do before and after. But again, you do this consistently, you do it well. What are the strategies you use in your practice?
Well, basically, and there are two sides to this story, patients have to buy into their disease state, and that means communication. The more you're in their face talking about whatever it is, in particular hypertension, since it's so rampant in the African American community, we get a better response. That's why we see newer approaches where we have nurses calling patients under the chronic care management approach, or annual wellness exams that don't include a hands-on or a face-to-face visit with a doctor. Actually gives the patients more points on the graph to say, I had contact with the system, with the healthcare delivery system that is advising me on my care, and they learn in different ways.
Yes.
After a point, they're like a coach on the team, okay? They're not really listening to the advice that you give, so you have to look at a different way of getting that message across to them, and sometimes it takes other people to do it. Now, that might be hard for practicing physicians to swallow because we're the tip of the spear. We sometimes think that everything turns on what we say, but in some instances, people will respect and respond to a old message coming from a new person in a different way. So we see that is really a huge factor now in terms of treating patients and getting them to be more compliant in that old term, treat to target, treat to goal.
Okay, team-based approach,
Team-based
not just you,
approach.
everybody
Right.
involved.
Everybody involved, good. We're up against a break, Ken. We'll be right back with more primary care after this.
First time I tried Vicodin, it was laying around my mom's house. I didn't know they'd be this addictive. I didn't know how far I'd go to get more.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
Welcome back. We're here still with Dr. Ken Jamerson, Professor of Medicine at the University of Michigan School of Medicine in Ann Arbor. Dr. Jamerson, we go back a long way in terms of treating hypertension, and we've seen some of the points along the way. We've also seen a great deal of progress. I think back when the ASK study was started, and even further back than that, the ALL-HAT study, we had control rates in the African American community that were the 22, 27%, somewhere in that range. And now we have more than doubled that in some instances, and studies have tripled that, getting to some better numbers, but still not enough to have the kind of outcomes that we want in terms of heart attack and stroke. What is the role of the primary care physician in this whole thing of getting patients to be compliant and actually getting those numbers and documenting those numbers that we need?
The quarterback throwing to the wide receiver, and the running back.
Sound like a Michigan situation here.
I think the primary care provider is really key. First line of conception, implementation, and the idea of how the metric, how well you're doing. It all resides in primary care's purview. And in the previous segment, you talked specifically about things you do to make it more team-based, using the pharmacists sometimes, but it really begins with the primary care and starts and ends there. And experts provide an opinion, and they fade away.
That's true, and the game goes on, okay, in terms of getting the numbers that we want out of the treatment modalities that we achieve. Cultural sensitivity. Who's taking care of these patients? Who's actually delivering the message? Are you seeing that there is a difference in terms of the provider network and what it looks like and what it sounds like in terms of patient acceptance?
That's an interesting question, because my perception would be that we would recognize, African Americans would see another African American say, yeah. Mm-hmm. It turns out when it comes to your health, you care about how good they are and not necessarily what their complexion is. There's some older folks who really feel that blacks went to inferior medical schools when they couldn't go to mainstream or predominantly Caucasian medical schools. And some older people don't want a black doctor at all. But we had an opportunity to look at preferences. We did a clinical trial, and we took people who said, yes, we want to engage, and people who said no. We wanted to know their opinions. Was it the Tuskegee syphilis study? How did people feel about that? How did they perceive racism in terms of their decision? We looked at this question in white hospitals in the South that had white doctors and white study staff. We looked at this at Meharry, and we looked at it at Howard with black institutions. And I'm the hybrid. I'm at a white institution, U of M, but I'm a black investigator. And what we found is that it didn't matter what the institution was. It didn't matter what the color of the person was. Patients are smarter than that. What they responded most to was your ability to communicate the healthcare benefit of the research and how it would help them as an individual. And if you didn't do that well, you didn't get patients to participate. They were more likely to be in the no group. And there are some well-organized Caucasian women who communicated that message well, and they were the best recruiters. There are some organized African Americans who did not communicate that message well, and people didn't go with them just because they're African American. So what we found is that you don't need a black coordinator. You need a good communicator. You need someone to tell them in a way that they can identify well what the benefit is for them if they comply with the therapy, if they participate in a clinical trial. Just tell me the benefit, and I can take it irrespective of what you look like.
You mentioned clinical trials now at least twice, and the participation of African Americans in clinical trials is legendary. It goes back to some of the things you just mentioned, like Tuskegee. You know, that was even one set of action here in the 20s on the east side of Detroit, where infection was released that, you know, gets lost in history, that nobody talks about anymore, but the same kind of concept. There's a trust factor here, though, that's missing. Patients still have a distrust, a disconnect when we talk about participation in clinical trials, and it has hurt us also. I know you're aware of the National Cancer Institute apology to African Americans and to the National Medical Association for them not stepping up and being more proactive on what works for certain things, in particularly why tamoxifen didn't work in black women with breast cancer. Those kinds of things, and we see more and more of that not just leaking out, but coming forward in terms of our discussion and our research, But the basis of it is having people appropriately assigned to have a trust factor in researchers to bring these kinds of results out. Because if African Americans don't participate in clinical trials, we really don't know what will work.
You're absolutely right. So in our study where we looked at people who said yes and who said no, Tuskegee was equally important to people who said yes as it was to people who said no. So it's not the discerning feature. Everybody's concerned about it, but if you want to transform decisions, you've got to communicate that knowledge in a way that people can receive it. So trust is important, but beyond trust, an individual needs you to communicate with them the knowledge necessary for them to make that right decision.
Ken, this has certainly been a pleasure. Thank you so much for joining us on the program today. It's always a pleasure.
It's my pleasure.
Good. Thank you. We'll do it again. That's all the time we have left with Dr. Kenneth Jamerson, Professor of Medicine at the University of Michigan Medical School in Ann Arbor. Stay right there. We'll be right back with some final thoughts.
This is what high blood pressure looks like. Talk with your doctor to create a treatment plan that works for you. Go to loweryourhbp.org.
Some final thoughts on hypertension or high blood pressure. We've been treating this disease state for a long time, and over the last 20 years have made significant progress. However, are we there yet? Not by any means. But thanks to the development of new medications and research and increasing our body of knowledge of what we know about hypertension, we have done better. We have to continue because we are not there yet. We have to treat to target, treat to goal, especially with the new guidelines that have re-regulated what the normals are. So therefore, the march toward treating high blood pressure continues. Thank you for joining us on Primary Care, and we'll see you next time.